Now, I'll just deal with the nuances, meaning the finer points and the aspects of all approaches, where you need to take care of all the structures there, how do they, where they are placed, we'll tackle one by one. Now, the most common approach that the approaches that we approach the shoulder girdle is deltopectoral, anterolateral approach. There is a lateral approach, and there is a posterior approach. Posterior approach is the Jude's approach for the scapula and the glenoid. And the anatomy of the shoulder, just to highlight here, is we encounter initially in the superficial plane the cephalic vein. Then there is deeper down, we have to take care of the anterior circumflex artery, which is almost 6 to 8 centimeters away from the GT. And posterior circumflex humeral artery, it is again in the same plane. Musculocutaneous nerve, which is almost 1.5 to 2 centimeters away from the pectoralis major insertion. And the axillary nerve, again it is the same plane as the circumflex axillary artery. What are the landmarks that we put into so that we don't fall into trouble is, there are two landmarks, coracoid process and the deltoid tubercle, but at the shaft point. So you approach the interval between the deltoid and the pectoralis major. It is an internervous plane. Deltoid is supplied by axillary artery nerve, and pectoral is by the lateral pectoral nerve. So this is how you go about deltopectoral fascia. You incise, you see the vein. The vein with the deltoid is retracted laterally, and deep down you see this deltopectoral groove. Inside of you see this clavipectoral fascia. Now clavipectoral fascia is a thick fascia which might misguide you. So you palpate the coracoid first. From then on, laterally is what your dissection is, not medially. So you take an L-shaped incision at that level, like this, and then that is how you enter this. So the moment you take off the clavipectoral fascia, you will see into the subscapularis tendon. As you palpate superiorly, you will encounter the greater tuberosity, lesser tuberosity there. So from then on, if you want to enter the joint, we have got three ways why you can do. And inferior to the inferior edge of the subscapularis, there will be the latissimus dorsi, which will be arching, wrapping around the humerus. So that is your inferior most point. Beyond that, you don't try to do anything there, because there are vital structure. You may damage the circumflex humeral artery. So what are the pitfalls? The musculocutaneous nerve, as I said, it is almost 1.5 to 2 centimeter lateral to the pectoralis and inferior 2.5 centimeter inferior to the coracoid. If you put a retractor over there and very violently retract, you are likely to damage the musculocutaneous nerve. So there you should not have any violent retraction. So how do you go about the intra-articular exposure? Because as I said, there are vital structures all around. So you need to take off all these structures. So how do you go about? Lateral, in front of the biceps, that is the bicipital groove, over the lesser tuberosity, along the line of the biceps tendon, long head of the biceps tendon, you incise. So that is the way you go about. If you incise, you will be in the joint. That will be the superior edge of subscapularis. So that is the safe interval. It is the interval between the rotator cuff and the biceps long head. So if you go along that, but it should be along the fiber, along the length of the long head of biceps, not across. If you go across, then you are likely to cut the rotator cuff there. The other approach is, suppose if you have a fracture over there, then along the fracture you can expose the joint. But while exposing the fracture, you don't cut anteriorly, but along the long head of biceps or the length of the supraspinous tendon. Inferiorly, if you go down, as I said, as you can feel the superior edge of the latissimus, that is the inferior edge. So from the superior edge of the subscapularis and the inferior edge, below that you will feel the latissimus dorsi superior edge. That is the whole width of the subscapularis tendon. So either you incise it over the tendon, do a tenotomy, raise a flap, and as you go, raise a flap between the capsule and the subscapularis, incise the subscapularis towards the glenoid joint, not towards the insertion, so that you don't have fibrosis over there. Or you can peel off the whole subscapularis and again put it along the capsule. Or you can do an osteotomy of the lesser tuberosity. There are the three ways you can go about. Is there an extension to this? Proximally, if we extend, then we have to osteotomize the clavicle to approach the brachial plexus, as was discussed earlier in the clavicle fracture. But there again, the most superficial structure after opening, or rather after cutting the clavicle, is the muscular kidneys nerve. So that again can damage in open clavicular fracture because very superficial it is. So when you put a retractor over there, see to it that you under vision you do it. Don't do it blindly. So what is the distal extension? Distal extension is like the deltopectoral, so the anterolateral approach of the humerus. Extend that approach. Go lateral to the belly of the biceps. Retract the belly. Down you will find the brachialis. Lateral 1/3 will be supplied by radial nerve, medial by the medial nerve, and then through the interval the whole humerus can be exposed. So what is the anterolateral approach of the shoulder? What you can tackle through it? You can tackle rotator cuff injury, repair of long head of biceps, acromioclavicular joint decompression, anterior shoulder decompression. Now, how is this approach? It is again done in the beach edge approach. You extend from they take an incision from the acromion to the coracoid. Deep dissection, you will feed anterior 1/3 of the deltoid, you will be seeing there. Erase the deltoid, or you can split the deltoid, whatever your surgery you may plan. If you are trying to reconstruct, then you have to incise the whole of deltoid, raise the flap, and then do it. Or if you just want to do a decompression, split the deltoid and do the decompression subacromial, whatever you have planned for. Again here, the incision, if you are doing reconstruction of a rotator cuff, see to it your retractor doesn't go deep enough. Deep enough, because we have a tendency, if you have to retract, you may put a retractor deep enough, and deep enough, you will damage the axillary nerve. So your retractor should not go beyond 5 to 6 centimeters. What are the dangers? There is an axillary nerve, an acromial branch. You have an acromial branch which is very small. You can actually ligate or cauterize it. The transdentoid lateral approach, which is called the split deltoid approach. Now there are three main bulk of the deltoid fibers: the anterior 1/3, the lateral 1/3, and the posterior 1/3. The posterior 1/3 is called the spinal part, lateral 1/3 is called the acromial part, which is originating from the acromion, and the clavicular part, which is originating from the lateral 1/3 of the clavicle. Now, the nerve, axillary nerve, here once it exits from the quadrangular space, it divides into two. It supplies the posterior 1/3 by giving a posterior branch, and then it curves anteriorly and supplies the acromial part as well as the clavicular part. So now you have two intervals. You can approach the interval between the clavicular part and the acromion, or the acromion part and the spinal part. So when you approach it, after dissecting the skin and all, this is just danger zone. Meaning a danger zone as in, if you are doing it blindly then. But if you are doing a split approach, if you are visualizing the axillary nerve, what Tanna sir always says, I see and do it. So that means I am safe. That also I do generally, but if you are doing it blindly, then see to it that zone between 5 to 8 centimeters is the zone which is a no-touch zone. So this is the infraspinatus here. This is the danger zone that is there. Axillary nerve. What is the approach extension? You can extend it proximally. If you are supposed to do any suprascapular repair, muscle repair, or decompression, then you can osteotomize the acromion and then again refix it. That is the proximal extension. Distally you can extend, barring the central part of it. But if you are doing under vision, you can do it safely by extending it distally. Posterior approach. Now what are the indications of posterior approach? Repairs of posterior dislocation, the chronic repair, the repair for in recurrent posterior dislocation or subluxation of shoulder which is not getting reduced by any means, or it is recurrently subluxating, glenoid osteotomy, biopsy and excision of tumors, removal of loose bodies, pyoarthrosis can be drained from there, or fracture scapula neck, and posterior fracture dislocations. Now here, as you see, there is the vital structure that is important is, once you approach it from posteriorly, the quadrangular space needs to be really taken care of. Meaning what? Once you do it, you have to be aware that the structures are there in the quadrangular space. Now, how do you identify quadrangular space? Now, you make this like this, and this is how it is. This is the humerus lateral head. This is teres minor, and this is teres major. For you, it is like this. Okay? And this is long head of tricep. So there is circumflex, there is axillary artery and axillary nerve passing through the quadricular spine, circumflex capillary artery passing through this. What we have to do is between teres minor and infraspinatus. The position of the patient is lateral. Either you take a Girdle approach, where you take an incision all along the acromion, the spine of the scapula, cut the deltoid posterior fibers, that is the infraspinatus, identify the interval. It is very difficult to identify. There is a thick fascia over there. See to it, you incise it properly, identify it properly. Now you go between the interval of infraspinatus and teres minor. If you be in that interval, you are not damaging either the circumflex scapular or the axillary and superiorly. But here again, you don't have to retract very violently suprascapular, because the there is a suprascapular nerve which is coming from the notch. Now, if you keep violent retraction, then you are likely to damage the suprascapular nerve. Or you can approach to the dead lateral approach. Here again the same thing. Inside the fascia. Now, you have identified. As you go proximally, after you divide, you will see the insertion of the long head, the origin of the long head of triceps. Now, as I said, origin of the long head of triceps and the teres minor. You form a quadrangle. You that, so you don't retract violently over here, you are likely to damage the axillary nerve and artery. And infra, there is the subscapulary, there is the circumferential scapular artery. So violent retraction inferiorly is not done, violent retraction superiorly. Now deltoid here is not elevated, but if you elevate it very violently, the deltoid artery or the axillary nerve which gets pierced gets stretched out and you will have deltoid palsy. So here there is no indication for violent retraction. You have a narrow window, whatever is sufficient, only expose that much. This is for a spinal glenoid notch that is there. You see the suprascapular now. This is the arthrotomy. Suprascapular nerve, that is, these are the two areas which are axillary nerve and suprascapular nerve. Thank you.